Okay, good evening, everyone. My name is Jatin, and I'm from the batch of 2015. So today's topic will be the seventh in the webinar series of the Rural Service Bootcamp, and today's topic is hyponatremia. Our moderator for the day is Dr. Manju Sebastian. She is an alumnus of St. John's, and currently she is an assistant professor in general medicine at SR Medical College, Chennai. And our topic is a very commonly seen topic in rural centers, and it's the most common dyslexia we see in clinical practice. And it is a pretty vast topic, so I don't think we can cover the whole of hyponatremia in one session. So uh, we thought that covering the diagnostic approach in this session would do justice to it. Without further ado, we'll be beginning the session. Hyponatremia diagnostic approach. Let me know if there is any problems with the presentation or the audio at any point of time. So there are a few basic concepts which we should know before delving into hyponatremia. So total body water. So total body water, an approximate measurement will be 60% of lean body weight in men in kgs and 50% of lean body weight in women. And total body water can be divided into two compartments, the intracellular fluid and extracellular fluid. So extracellular fluid is only 1/3 of the total body water, and that can be further divided into interstitial compartment and the intravascular compartment. So the intravascular compartment is about 25% of the extracellular fluid. So normally, there is an equilibrium in the osmolality between the ICF and ECF. So what happens in hyponatremia is the osmolality in the ECF is less than the ICF because there is less sodium, because there is less solute in the ECF. Water moves into the ICF. So why is hyponatremia dangerous? So what happens is when water moves in from the extracellular fluid compartment to the intracellular fluid compartment, this will happen. Your brain can, there will be cerebral swelling. So cerebral swelling can cause a myriad of symptoms ranging from very mild to very severe symptoms as well. So sometimes hyponatremia can be asymptomatic, and mild symptoms can be headache, irritability, difficulty concentrating, altered mood, or depression. And moderate symptoms will be slightly more severe, like nausea, confusion, disorientation, altered mental status, unstable gait, falls, tremors. And severe symptoms will be vomiting, seizures, drowsiness, severe drowsiness, respiratory distress, coma. So we'll be dealing more with symptoms in the next class. So this was just to get an idea of what kind of symptoms a patient can present within hyponatremia. So another concept with which we should be very clear about is ADH or vasopressin. So
Jatin, your audio has gone off now.
Hi all. I think Jatin has got run into some trouble with his presentation. His computer has is not responding. Manju ma'am, in the meanwhile, can you take over and cover for some time? He's getting
Sure.
it ready. Yeah.
All right. So Jatin was basically talking about the role of ADH and vasopressin. So essentially, it's important to know that when you have hyponatremia, it happens due to either an excess of free water in your body, which can occur when there is intake of excess free water or there is an impaired excretion of the free water. So most of the time, it doesn't have anything to do with the sodium. It's more about the sodium water balance, and that too it mostly affects the water balance. So either there is excessive intake of your free water or an impaired excretion of the free water. So here in the excretion of the free water, we have that hormone here that he was going to talk about, which is ADH or vasopressin. So ADH, as you all know, is secreted by the posterior pituitary. So as the name suggests, it's an antidiuretic hormone. So it prevents diuresis. It prevents excretion of the free water. So ADH is very closely regulated in our body. It's regulated by the osmolarity of our body as well as the thirst. So what happens is normally if our osmolarity rises, normally our serum osmolarity is maintained at a level of around 275 to 290. So when you have a condition where your osmolarity rises, basically your body is getting dehydrated, your thirst gets stimulated. This thirst center is located in the hypothalamus. And once the thirst gets stimulated, there is also activation of the antidiuretic hormone. So what happens is it prevents excessive excretion of your water, free water, and this aims to reserve the water in your body. And that's how you can prevent any rise in serum osmolarity. So, whenever there is an abnormality in the secretion of the ADH, that means excess water, free water gets conserved in the body, that can also result in a hyponatremia because the balance between the sodium and the water will be affected. The other important thing to remember about physiology in hyponatremia is about the role of another hormone called aldosterone. So aldosterone is what acts in our distal convoluted tubules and the collecting ducts. Basically, aldosterone is important for the conservation of sodium. It acts on what we call the ENaC channels, which are the epithelial sodium channels. So when aldosterone is released, so aldosterone is released through a mechanism called the RAS pathway. You'll remember the RAS pathway. So there is something called a renin angiotensin aldosterone system. So any condition where the body perceives as the blood volume is decreased, what happens is when there is a reduction in the blood volume, the blood flow to the kidneys will be reduced, and this results in the secretion of this hormone called renin. Renin further results in the activation of angiotensin. Angiotensin results in the secretion of aldosterone. So aldosterone acts on the epithelial sodium channels, which are located in our distal convoluted tubule and collecting duct, and it aims to preserve your sodium. So this is another way. By preserving sodium, along with sodium, you will have conservation of water. So aldosterone also responds to any decrease in the effective blood volume or arterial blood volume, and it aims to conserve sodium and water, and this further improves our circulating blood volume. So again, another condition that can result in excessive secretion of aldosterone is when you have a decrease in the effective arterial blood volume. Jitin, you're able to access your slides now?
Chetan is still restarting his computer. Is almost there. In the meanwhile, I've put up the presentation. So Manju ma'am, if you want me to navigate through the presentation, I can do
Yeah,
that.
just you can
Yeah,
go to that ADH slide.
1 sec. Yeah, here. Is that what you want? Oh,
Yeah, yeah. So this is basically what we were just covering.
yeah. Jatin is back, I think. Jatin?
Yeah, hi. Can you hear me?
Yeah,
Yeah,
Jatin.
you're on.
Over to you.
Yeah. Can you see the screen also?
Yep.
Yes,
Yeah.
yes.
Okay. Yeah. Sorry about that. My system crashed. So yeah. Yeah. So I think I stopped at ADH. Yeah. So ADH or vasopressin. So this is also a very important uh, concept to know about before we delve into hyponatremia. So where is ADH produced from? So ADH is synthesized by the hypothalamus, and it is released from the posterior pituitary. So the hypothalamus has certain osmoreceptors which regulate the amount of ADH which is released. So these osmoreceptors are in direct contact with the blood. So since there is no blood-brain, there's a lack of blood-brain barrier here, and there's direct contact, the osmoreceptors can directly detect the osmolality of the blood. So this is how the hypothalamus is able to release ADH in response to the plasma osmolality. So osmolality is dependent on osmotic pressure. And osmolality, what is osmolality? Osmolality is basically the measure of solute in the plasma. So that is plasma osmolality. So osmotic pressure is dependent on plasma osmolality, and that in turn is affected by the plasma volume. So in states of hypovolemia, there is less solvent. Plasma osmolality will be more because the concentration of solute increases in a hypovolemic state. And this can trigger the hypothalamus to secrete ADH. So there's one more mechanism by which hypovolemia can increase ADH secretion. So our left atrium, the carotid artery, aortic arch, these structures have baroreceptors. I think someone's audio is on. Yeah. So the baroreceptors in the left atrium, carotid artery, and the aortic arch can detect changes in the arterial blood volume. So if the blood pressure reduces, the baroreceptors will relay this information to the hypothalamus, and this can also stimulate release of ADH. So bottom line is states of hypovolemia can generally increase ADH secretion. So what? And another thing is when there is decreased, when there is hypovolemia, there is reduced kidney perfusion also. So when there is reduced kidney perfusion, the GFR is also reduced, and this will stimulate the renin-angiotensin aldosterone system, and this will also stimulate ADH. So all these causes of hypovolemia and increased plasma osmolality can stimulate ADH release. So what does ADH do? So ADH acts at the kidney. So it acts at the DCT and the collecting duct to reabsorb water. So when you reabsorb water from the kidney into the intravascular space, the osmolality is going to decrease because you're diluting the intravascular space. And since you're reabsorbing water from the urine osmolality is going to increase. You're concentrating the urine. So ADH is going to decrease your serum osmolality. It is going to increase your urine osmolality. And these are the two main actions of ADH. And ADH has another action also in higher concentrations where it can act directly on the blood vessels to increase peripheral vascular resistance. And this will also result in an increased blood pressure. So hypovolemia will stimulate ADH release, and ADH is going to reabsorb water from the kidney, and at high concentrations, it also increases peripheral vascular resistance and increases blood pressure as a result. Okay, so this flowchart is basically a summary of the mechanism of how ADH is produced, ADH or vasopressin, and the end result is increased arterial blood pressure. Okay, so what is hyponatremia? So hyponatremia is primarily, even though the name is about sodium and all, it is primarily a disorder of water balance or the distribution of water in the ICF or the ECF. So in hyponatremia, your plasma sodium concentration is going to be less than 135. Normal range is 135 to 145, and hyponatremia it is less than 135. So what happens in hyponatremia? Any of these processes can cause hyponatremia. Either direct sodium loss can cause hyponatremia, or if the elimination of water from the body is limited, that is going to cause a dilutional effect, and sodium concentration is going to decrease, or anything which expands the volume around a fixed sodium content. So that is also going to show up as a low sodium concentration. So, what are the what are the important steps in the diagnostic approach to hyponatremia? So, obviously, as in all cases, history is very important. So, history will include your symptoms and any medication which the patient might be having, and all those things. So, very detailed history is very important. And clinical examination is also extremely important, especially the volume status of the patient. So whether the patient is hypovolemic, euvolemic, or hypervolemic is very important to in the diagnostic approach for hyponatremia. And other tests which are of significance are obviously your routine bloods. Serum electrolytes is how we are going to find out whether the patient has a low sodium or not. And the sugars are also relatively important, and the RFTs are also very important. And these three tests we may not be very familiar with, but are of importance to like find out what the cause of hyponatremia is. So plasma osmolality is one test, urine osmolality is the other one, and urine sodium is the other test. So history, clinical examination, electrolytes, plasma osmolality, urine osmolality, and urine sodium. So this flowchart is going to be very important in today's class. So we'll be revisiting this flowchart at multiple points. So right now we are at this stage. Serum sodium, you found out that the patient has hyponatremia. Serum sodium is less than 135. So what is the next step? So the next step, as shown in the flowchart, is to measure plasma osmolality. So what is plasma osmolality? I already talked about plasma osmolality. It's a measure of the different solutes in plasma. So by definition, number of osmoles of solute per kilogram of solvent. So normal range of plasma osmolality is 280 to 295. And how to calculate plasma osmolality? So this is a formula which you can use to calculate plasma osmolality: 2 into sodium concentration plus glucose divided by 18 plus BUN divided by 2.8, where glucose and BUN are in milligrams per deciliter. If you don't have BUN, you can calculate it from the urea also. So when you do RFT, you're going to get urea, create uric acid. So urea, you can calculate BUN from urea. BUN is urea by 2.14. So this formula is very important. If you know this formula, you'll be able to calculate the plasma osmolality. So most patients with hyponatremia have a low plasma osmolality. So what if the plasma osmolality is not low? So normally, if we think if the patient has hyponatremia, solute content is less, patient should have hyponatremia, right? So patient should be should be having hypoosmolality, but there are conditions where the osmolality will be high or normal also. So we'll have a look into that. So say serum sodium, as we found out, is less than 135. Next step is to measure plasma osmolality. So either plasma osmolality can be within the normal range, or it can be sometimes high, like that is unexpected. It's like contradicting. Patient has hyponatremia, but the patient's osmolality is high. And as expected, plasma osmolality can be low also. So first we'll talk about hyponatremia. So hypertonic hyponatremia, you found out that the sodium is low, but the plasma osmolality is high. So this happens in cases where an osmotically active solute other than sodium accumulates in the ECF. So there is something else in the blood which is causing the osmolality to be high. So this will draw the water into the ECF, and when another osmotically active solute is there in high amounts in the blood, it will draw water into the ECF and it will dilute uh, the sodium content. So the sodium will turn up as low. So this is most commonly caused by hyperglycemia. So this is a rough measure of how much the sodium falls for every 100 milligram per deciliter. So plasma sodium can fall from about 1.6 to 2.4 for every 100 milligram per deciliter rise in plasma glucose. So hyperglycemia is the most common cause of this, and other solutes can also cause this. So one such example is your post-TURP syndrome. So post transurethral resection of the prostate, uh, during bladder irrigation, certain solutes such as glycine or mannitol or sorbitol can get absorbed into the bloodstream. And this can also draw water into the ECF and dilute the sodium content further. So the next type of hyponatremia is isotonic hyponatremia. So here, sodium content is low, but the plasma osmolality is within the normal range. So we call this is also called a pseudo hyponatremia. So this is basically a lab error. So it happens in cases where the bloodstream has increased lipids or increased proteins. So examples of such situations can be hyperlipidemia or recent IVIG administration or multiple myeloma where there is like increased proteins in the bloodstream. So what this does is it like lipids and proteins, they'll occupy space in the volume of the serum. So they're going to expand the volume of the serum. So this is different from like previous case where an osmotically active solute is uh, pulling in water into the bloodstream. But in this case, these solutes are just going to occupy space in the volume of the serum. But when you occupy space in the volume of the serum, also you're going to dilute the sodium concentration. So in these cases, your osmolality is going to be normal, but patient will be having hyponatremia. So we've reached this stage. We've covered hypotonic hyponatremia and isotonic hyponatremia. So what we are worried about so what we'll be covering in this class is hypotonic hyponatremia. So hypotonic hyponatremia is what we call true hyponatremia. So in hyponatremia, sodium content is low, solute is low, so therefore plasma osmolality is also low. So low plasma osmolality is anything below 280 milliosmoles per kilogram. So you found out that patient has hyponatremia, you found out that the patient has hypotonic hyponatremia. So the next step is to measure urine osmolality. Am I audible?
Yes, you are.
Yeah. Okay. So the next step is to measure urine osmolality. So patient has hypotonic hyponatremia. So urine osmolality, if it's more than 100, uh, we call the hyponatremia ADH dependent. If it's less than 100, we call it ADH. We say that ADH is suppressed. So why? So when you say when you say the hyponatremia is ADH dependent, what we are trying to say is that ADH is active, ADH is acting. So in a type of hyponatremia where the ADH is acting, ADH is reabsorbing water from the kidney. So ADH is reabsorbing water into the bloodstream and ADH is concentrating the urine. So when ADH is concentrating the urine, the urine osmolality is going to be high. So more than 100 is what most textbooks agree upon. And when in hyponatremia, the urine osmolality is low. That means the ADH is not acting appropriately. So if the urine osmolality is less than 100, we say that the ADH is suppressed. So what is urine osmolality? So we have already discussed osmolality. So it's a measure of it's a degree of the solute in the urine. So normally the appropriate renal response to hypoosmolality is to excrete a maximally dilute urine. So when your plasma osmolality is low, normally what should happen is the urine also should be dilute because your bloodstream is dilute. So a urine sample that is not dilute suggests impaired free water excretion due to appropriate or inappropriate secretion of ADH. So first we'll be covering cases where the urine osmolality is high, that is more than 100. So we call this ADH dependent. Why ADH dependent? Because ADH is acting and it is concentrating the urine, and that is why urine osmolality is more than 100. So we are done with plasma osmolality, we are done with urine osmolality. So the next step is to assess the volume status and check the urine sodium of the patient. So plasma osmolality is less than 280, urine osmolality is more than 100, so it is ADH dependent. So we've come to assessment of volume status. So assessment of volume status is mainly clinical. Okay, so that is very important: hypovolemic, euvolemic, and hypervolemic. So mostly we won't be confused between hypovolemic and hypervolemic. It will be pretty obvious. So what we have to differentiate between is hypovolemic and euvolemic, or euvolemic and hypervolemic. So these are some of the clinical features which we see in hypovolemic patients. So hypotension, orthostatic hypotension, rapid thready pulse, rapid shallow breathing, lightheadedness, syncope, cold clammy skin, poor skin turgor, dry mucous membrane, sunken eyes, and hypovolemic features can be shortness of breath, orthopnea, raised JVP, facial crackles, and pitting edema. Yeah, so assessment of volume status is very important and is mainly clinical. So first we'll deal with hypovolemic status. So in hypovolemia, the patient's water in the body is depleted. We already know that the patient's sodium is low. So in a hypovolemic patient, if the sodium concentration is low, that means sodium should be more depleted than water. So both are depleted and sodium is more depleted than water. So once we know that this is a case of hypovolemic hyponatremia, our next step should be to evaluate whether this is renal or extra-renal. So that is where urine sodium comes in. So under normal conditions, sodium excretion by the kidney equals dietary intake minus the small amount which is lost in sweat and feces. So this ability to match the dietary intake with excretion enables the ECF volume to be maintained within a narrow range. So what happens when there is hypovolemia? When effective circulatory volume is reduced, uh, this leads to activation of sympathetic nerves and activation of the renin-angiotensin-aldosterone system. And this will normally cause sodium retention in the kidney. This will normally cause sodium retention. And normally, hypovolemia should lower the urine sodium concentration to less than 15. So low blood volume is going to activate renin-angiotensin-aldosterone system. Aldosterone is going to reabsorb sodium from your kidney, and this should ideally lower the urine sodium concentration. On the other hand, volume expansion should have the opposite effect. So volume expansion should lead to a reduction in sodium absorption, and your urine sodium concentration should be high. So basically, the objective of urine sodium is that it's an indirect measure of the integrity of the kidney. So whether your kidney is at fault for your sodium loss, we'll be able to find out through urine sodium. It is a measure of the integrity of the kidney function. Okay. So urine sodium discriminates between extrarenal and renal losses of sodium. So as we discussed, the appropriate response to decreased effective circulating volume is to enhance tubular sodium reabsorption, and urine sodium is going to be low because of that. So if your urine sodium is low, that means that your kidney is not involved and sodium reabsorption is happening as expected. So if your urine sodium is low, that means cause for your hyponatremia is probably extra-renal. So if urine sodium is high, more than 20, so normally more than 20 will suggest a normal affecting circular volume or that you're losing sodium through the kidney. So it is a renal sodium wasting defect. So what are the renal and extra-renal causes? So renal causes are diuretics, hypoaldosteronism, and extra-renal causes are skin loss, vomiting, excess NG tube suction, diarrhea, third space leakage, pancreatitis. So let's see how these causes cause hyponatremia and the respective urine sodium values. So first we'll deal with renal causes of sodium, renal causes of sodium loss. So thiazide and loop diuretic. So if you've read about their physiology, you know that these are going to result in a decreased sodium reuptake at the kidney. So you're going to lose sodium like that, and because there is a decreased sodium reuptake, your urine sodium is also going to be high. And hypoaldosteronism. So hypoaldosteronism, there is less aldosterone. Aldosterone normally helps with sodium reuptake, but because there is no aldosterone here, so there'll be a decreased sodium reuptake, and urine sodium is going to be high. And we will talk about cerebral salt wasting in a bit. All right, so these two causes are going to cause decreased sodium reuptake, hyponatremia as a result, and also urine sodium will be more than 20. And also history is very important in both these cases. History will help you determine the cause even before you actually may even find out the urine sodium. So history is extremely important at every step. what is cerebral salt wasting? So cerebral salt wasting also, so remember we are in hypovolemic hyponatremia and urine sodium is high. So cerebral salt wasting can have a couple of causes. So head injury, brain tumor, intracranial surgery, stroke, hemorrhage, so mainly cranial cause, intracranial causes, and sometimes it can also occur in the absence of cerebral disease. So the mechanism for this is not very clear. So some of the hy- hypothesized mechanisms are like brain injury can cause an increase in sympathetic activity and increase the adrenergic activity, which will increase the kidney perfusion, and uh, as a result, natriuresis can occur, and brain injury itself can cause the release of natriuretic peptides like the brain natriuretic peptide, and this will also cause natriuresis to occur. Right. So this slide will be important when we talk about SIADH later. So as of now, just remember that the cerebral salt wasting is occurs in hypovolemic patients. It's a volume contracted state. Okay, so we've reached at assessment of volume status. So we found out that the patient had hypertonic hyponatremia, and then we checked the urine osmolality. Urine osmolality was more than 100. So because of that, ADH is acting, urine is concentrated. So next step is to assess volume status. So we found out that patient was hypovolemic, and if urine sodium is high, what are the causes? So if urine sodium is high, it's mostly renal solute loss, and causes are diuretics, hypoaldosteronism, and cerebral salt wasting. So what if the patient is hypovolemic but urine sodium is low? So that means your kidney is okay. So kidney is absorbing, ADH is acting in the kidney, and sodium is being reabsorbed normally in response to hypovolemia. So your urine sodium is going to be low. It's not going to be high. So why do you have hyponatremia and extrarenal causes? Skin loss, bleeding, all these causes can lead to direct sodium loss. And then they can lead to, because of this, there will be volume depletion and ADH secretion. And then water reabsorption will further cause a dilutional effect and can contribute to the hyponatremia. So just a note here, like in here we've included vomiting and excess NG tube suction. Sometimes in acute cases of vomiting, the urine sodium can be high. So that will settle later. The reason why is that because initially, because of vomiting, you can have you'll be having acid loss, and the kidney to compensate for that will try to excrete bicarbonates. And when the kidney is secreting bicarbonates, it also secretes sodium along with it. So because of that, in the initial stages of vomiting, you can have a high urine sodium, but later it settles, and once the vomiting settles, urine sodium is generally low. So in extrarenal causes, urine sodium will be generally less than 10. So we've covered hypovolemia, where urine sodium is high and urine sodium is low. Urine sodium is low means that there is extrarenal solute loss. So next we'll be covering hypovolemic status. So hypovolemic status, we'll be mainly talking about congestive heart failure, cirrhosis, liver cirrhosis, and nephrotic syndrome. And in all these cases, the urine sodium is going to be low. So what happens in congestive heart failure? In congestive heart failure, you're going to have a reduced cardiac output. So because of a reduced cardiac output, the effective arterial blood volume is going to be low. So since the effective arterial blood volume is going to be low, we talked about the baroreceptors and the atrium and the carotid arch earlier. So that because these baroreceptors detect a decrease in effective arterial blood volume, ADH secretion is going to happen. And because of ADH secretion, water is going to get reabsorbed into the intravascular space. As a result, you're going to get hyponatremia. In cirrhosis, what happens is because of portal hypertension, certain vasodilators are released into the portal circulation, and they can escape into the systemic circulation and cause vasodilation at the kidney. And this will cause RAS stimulation, angiotensin II secretion, ADH secretion, and water reabsorption. And also in nephrotic syndrome and cirrhosis, you're going to have hypoalbuminemia in nephrotic syndrome because of loss of albumin, and in cirrhosis because of decreased production of albumin. So because of hypoalbuminemia, you're going to have a decreased intravascular ability to retain water. And because of this, a decreased effective arterial blood volume. And this will in turn result in ADH secretion, water reabsorption, hyponatremia. So we've covered hypervolemic cases, hypervolemic causes of hyponatremia also. So why is urine sodium less than 10? Because the kidney is acting normally. The kidney is acting how it should be to uh, hyponatremia. Like the kidney is reabsorbing sodium normally, so urine sodium is going to be low. Yeah, so euvolemic status. So euvolemic status, volume is normal. So some of the causes are cortisol deficiency, hypoaldosteronism, hypothyroidism, and SIADH. So here the urine sodium is going to be high. So we'll talk about why it is high. So the first thing you have to rule out is the endocrinopathies. So SIADH is a diagnosis of exclusion. So you only make the diagnosis after you've excluded the other things. So first things you have to rule out are your hypothyroidism, cortisol deficiency, and hypoaldosteronism. So first we'll talk about cortisol deficiency. So normally what happens is hypothalamus will secrete your corticotrophin releasing hormone that will act at the anterior pituitary. It will cause the anterior pituitary to release the adrenocorticotropic hormone, and that will also act at the adrenal cortex to release your cortisol. So your cortisol via a negative feedback will inhibit your anterior pituitary. It also inhibits the posterior pituitary to decrease the secretion of ADH. It also has a direct effect on the hypothalamus. This will also cause a decrease in secretion of ADH. So bottom line is cortisol uh, regulates the secretion of ADH by inhibiting it. So what happens when there is cortisol deficiency? This whole thing is going to get compromised. So if there is cortisol deficiency, it is not going to regulate ADH release by restricting it. ADH release will be more. So in cortisol deficiency, ADH levels are going to increase. And there is one more thing, like cortisol helps with sodium reabsorption at the PCT. So if there is cortisol deficiency, uh, there is less sodium reabsorption. So urine sodium is going to be high. So your hyponatremia is because of increased ADH levels, and your increased urine sodium is because of cortisol deficiency, because cortisol helps with reabsorption at PCT. Because it's deficient, urine sodium reabsorption is not happening. So that was about cortisol deficiency. Now, hypothyroidism. How does hypothyroidism cause hyponatremia? So hypothyroidism will decrease cardiac output. How does it decrease cardiac output? So hypothyroidism will cause a decrease in heart rate and contractility, net result of which will cause a decreased cardiac output. And a decreased cardiac output, as we discussed earlier, will stimulate ADH because your baroreceptors are going to detect the effective arterial blood volume. So the hypothalamus is going to release more, secrete more ADH. More ADH means more water reabsorption, and more water reabsorption means dilutional effect and hyponatremia. And decreased cardiac output can also decrease the renal blood flow, and decreased renal blood flow means decreased GFR. Decreased GFR means decreased water excretion, and that is also a decreased water excretion because of increased water is being retained. That is also going to cause a dilutional effect and cause hyponatremia. And hypothyroidism also directly has an effect in the sodium potassium pump, sodium potassium ATPase activity in the kidney. So because of hypothyroidism, this activity is decreased, and so it has a direct effect on tubular sodium reabsorption. So there is less sodium reabsorption from the urine. So your urine sodium is going to be high. So we've dealt with cortisol deficiency and hypothyroidism. So the next cause is syndrome of inappropriate ADH secretion. So SIADH. So what is SIADH? So normally we discussed that ADH is released from hypothalamus uh, in response to hypovolemia or an increase in plasma osmolality. So here in SIADH, as the name suggests, it is inappropriate ADH secretion. So it is basically non-physiologic release of vasopressin from the posterior pituitary or an ectopic source. It can be from the posterior pituitary or an ectopic source also. So but the main thing is it is non-physiologic. It doesn't follow your volume status or your plasma osmolality. So common causes of SIADH include neuropsychiatric disorders like meningitis, encephalitis, acute psychosis, cerebrovascular accident, head trauma. So you might notice that some of the causes here are overlapping with something which we discussed earlier, cerebral salt wasting. So we'll get to that later. So other causes of SIADH are pulmonary diseases like pneumonia, TB, positive pressure ventilation when the patient is on a ventilator, intubated, and acute respiratory failure, COPD, ARDS, and malignancies are also known to cause SIADH. Most commonly, your small cell lung cancer. And certain drugs are also known to cause SIADH. So most common drugs include antidepressants, particularly your SSRIs, and narcotics, antipsychotic agents, carbamazepine, chlorpropamide, cyclophosphamide. So these are some of the most common drugs which can enhance the release or effect of ADS of vasopressin. So as I mentioned earlier, SIADH is a diagnosis of exclusion. Okay, and these are the other features which you'll see in SIADH. As it is going to be hypoosmotic that we've already covered in the flow chart. Urine osmolality is more than 100. That has also been covered. A patient will mostly be euvolemic. And you have to also rule out absence of conditions which otherwise stimulate ADH secretion. That is why I said it's a diagnosis of exclusion. We are excluding everything. Then we are reaching at the diagnosis of SIADH. So another finding which we see in SIADH is that ADH is going to get secreted. So there's going to be water retention. So as a result of water retention in a euvolemic patient, there's going to be expansion of extracellular fluid also. So because of extracellular fluid expansion, there is going to be reduced sodium and uric acid reabsorption. So this will cause an increase in uric acid excretion. And in SIADH patients, normally you see a low serum uric acid. So low serum uric acid is normally seen in SIADH. That is also a very important finding, can help out clinically. So you can refer to this table later. This is basically a, a table showing different causes of SIADH and how long these causes can have its effect, how long SIADH can last. For example, like in a stroke, maybe SIADH can last for about 1 to 2 weeks. So as we discussed, SIADH, there is an inappropriate release of ADH. There is water retention. There is fluid overload as a result. And as a result of fluid overload, the heart is going to release something to counter it, such as ANP, atyl natriuretic peptide. And ANP is going to inhibit RAS, and inhibition of RAS is going to result in low aldosterone levels. And because of low aldosterone levels, there'll be less sodium reabsorption from the kidney. And as a result, you're going to have natriuresis. So that is why SIADH also has a high urine sodium. And water retention also causes increased GFR, which will also have a negative feedback at the RAS. And because of that, you're going to have low aldosterone levels. As a result, less sodium reabsorption from the kidney and natriuresis. So your urine sodium levels are generally high. So we've covered euvolemic status also. So urine sodium is high. Causes are endocrinopathies. After we've ruled that out, SIADH. Okay, so right now we've covered this part of the flowchart. So we've found out that the patient has hypotonic hyponatremia. Urine osmolality wise, patient has high urine osmolality. So we've covered all the causes in high urine osmolality. So what if urine osmolality is less than 100? What if it is low? So urine sodium is less than 100 means that your urine is dilute. So your urine is dilute, your ADH is not reabsorbing water, your ADH is suppressed. So what are the causes for uh, hypotonic hyponatremia where your urine osmolality is low? So if urine osmolality is low, less than 100, ADH is suppressed. So causes like a broad headings would be increased water intake, low solute intake, and decreased water excretion. So first we'll talk about increased water intake. So increased water intake is like self-explanatory. Like if you take like a high volume of water. So this is otherwise called self-induced water intoxication. So your causes can be psychogenic polydipsia. So in some forms of psychosis, you see that the patients consume high volumes of water, and sometimes in marathon runners, in endurance event runners, sometimes they also consume like high volume of water, and this is also observed in ecstasy use and in other drug usage. So these are some causes where you observe self-induced water intoxication or primary polydipsia. So what happens here is there is increased water intake. So pretty straightforward. There is increased water intake. As a result, there is more water in your GIT. Because of that, more water is absorbed into the bloodstream. And when more water is absorbed into the bloodstream, it's going to dilute the bloodstream and cause a low plasma osmolality, which is why you have hyponatremia. And because of a low plasma osmolality, it is going to inhibit the hypothalamus. And because of that, less ADH will be released and there is less water reabsorption. And because of that, your urine osmolality is going to be low. There is less water being reabsorbed from the kidney because your hypothalamus was suppressed by a low plasma osmolality. There is less ADH, there is less water reabsorption, and urine osmolality is low. Urine is dilute. So this can also be measured. You can also use urine specific gravity instead of low urine osmolality. So low urine specific gravity is also a measure of how dilute your urine is. So again, history is extremely important. Like here, the patient is going to like you're going to find out from history if the patient is consuming a lot of water. So history is extremely important in this case as well. So we've covered increased water intake and how it causes hyponatremia and why you're getting a low urine osmolality uh, as well. So our next cause is a low solute diet. So this might be a bit confusing. So listen carefully. So a low solid diet. What is a low solid diet? So a low solid diet is basically it. A low solid diet will be basically carbohydrates and lots of fluids. You're not taking in proteins. You're not taking in salts. So that is basically a low solid diet. You can people also call this a tea and toast diet. So if you basically just consume some tea and have like bread or biscuits, it's your diet is not going to have much solute. It's going to be very low in solute and it's just carbohydrates and water. So that is what we call a low solute diet. Okay. So to understand how low solute diet causes hyponatremia, we'll follow this example. So we know that concentration is equal to solute by volume. So volume is equal to solute by concentration. So normal solute intake per day is around 600 to 900. And normal diet, that is a normal solute intake. So for the sake of the example, we'll take it as 700. So we know that the human kidney can generate urine osmolality from a minimum of 50 to a maximum of 1200. So the kidney can concentrate urine from a range of 50 with minimal ADH activity. So the most dilute urine kidney can make is a urine osmolality of 50, and the most concentrated urine the kidney can produce is 1200 at maximal ADH activity. So we'll insert these values into the formula. Okay, so we learned that volume is equal to solute by concentration. So volume is equal to solute 700 at minimal ADH activity 50. So 14 liters of urine at minimal ADH activity. So this is the most dilute urine the kidney will be able to generate with the solid intake. So the most concentrated would be 700 by 700 by 1200, which will be 0.58 liters. So this means that if your fluid intake is within this range, you will be able to eliminate the solute load and will be able to maintain sodium in your body within the normal range. So I hope that is clear. So in a low solid diet, so we took the solid content is 700 in the previous example. So take in the low solid diet, say solid is only 100. So now we'll put 100 into the formula. So solid is already 100, and we are going to take kidney at its most minimal ADH activity. So kidney, we are going to take the maximum amount to which kidney can dilute the urine. So that will be 100 by 50. So that will produce 2 liters of urine per day. So this means that if your intake is anything more than 2 liters, that is going to cause fluid retention, as a result, dilutional effect and hyponatremia. So even at minimal ADH activity, your output is going to be 2 liters. And if your intake crosses this 2 liters, it is going to cause hyponatremia. So this is why a low solid diet can cause hyponatremia, because your fluid intake has to match with your output, and the most dilute, like the kidney is acting at its maximum capacity to dilute your urine. Maximum capacity to dilute urine will be with minimal ADH activity. So even with that, the kidney is only able to produce 2 liters. And if your intake crosses that, it is going to result in hyponatremia. So this is how a low solid diet will cause hyponatremia. So this is also called tea and toast diet, as I mentioned earlier. So it's a diet which primarily consists of fluids and carbohydrates. So what is carbohydrates going to be metabolized as? It is going to be broken down into carbon dioxide and water. Carbon dioxide is going to be expelled out, and water is just water. And there's something called beer potomania. So that is basically people who chronically consume lots of alcohol, and also like the primary diet won't have a lot of solutes. So alcohol is also eventually going to be broken down into carbon dioxide and water. So there is no solute for the kidneys to eliminate. So because of this, uh, hyponatremia can easily occur. So low solute diet is going to cause less solute in the GIT. So that means there is less solute in the bloodstream, and because of that, there is low plasma osmolality. And because of low plasma osmolality, it is going to inhibit the hypothalamus, and ADH secretion is going to decrease. And because of that, there is less water reabsorption. And because there is less water reabsorption, your urine is going to be dilute, and urine osmolality in a low solid diet is also going to be low. Again, history is extremely important. So to show you how important history can be in this case, I'll give you a small example. So say a patient with hyponatremia, and an old lady living alone with hyponatremia came to you with a sodium of 122, and she's showing some symptoms of hyponatremia like fatigue and you know uh, altered mental status or whatever. So you found out that sodium is 122, and you gave her a fluid of 1 liter, so NS, and sodium has come back as 126, and the symptoms have improved. So you might think that this is dehydration, even when you didn't see any clinical signs of dehydration. But maybe if you had seen the specific gravity, urine specific gravity, and it was low, and if you found out if you asked her, if you took a detailed history about her diet, maybe you could have brought up a tea and toast diet. I'm not saying this is always the case, but it is important to rule that out also. So diet is very important when it comes to hyponatremia. So the next condition which we'll be covering in this case is end-stage renal disease. So in end-stage renal disease, the kidney won't be able to excrete much free water. Urine output is going to be extremely low. So as a result, more water is retained in the bloodstream. And this is going to dilute the plasma and cause low plasma osmolality. And low plasma osmolality will suppress the ADH. And as a result, you're going to have hypo. And if in this case also, if intake just uh, just about crosses the output, you're going to have hyponatremia. So your ADH is suppressed, and as a result, your urine osmolality is also going to drop. So these were the causes where urine osmolality is less than 100 and the ADH is not acting. Primary polydipsia, low solid diet, and end-stage renal disease. So yeah, so that brings us to the end of diagnostic approach. So I said that we'll talk about cerebral salt wasting and SIADH. So thing is, cerebral salt wasting and SIADH can have the same causes as discussed earlier. Any pathologies which has got to do with the brain, like an SAH, intracerebral bleeding. So both causes can cause cerebral salt wasting or SIADH. But the important differentiating factor here is in cerebral salt wasting, the patient will be hypovolemic. So that is very important. And in SIADH, patient will be euvolemic. So about management we'll be discussing in the next session, but this differentiation of cerebral salt wasting and SIADs is important because in hypo, if the patient is hypovolemic and uh, you think that the patient is having SIADs because of the cause, you're thinking it's an intracerebral bleed and hyponatremia is maybe because of SIADH, and the patient is actually hypovolemic. Your management in a euvolemic scenario will include fluid restriction. So because of that, if you mistake the cerebral salt wasting to be SIADH, you're causing further exacerbation of hypovolemia and it can be dangerous to the patient. So that is why cerebral salt wasting, differentiating between cerebral salt wasting and SIADH is extremely important. So remember that cerebral salt wasting is a volume contracted state. It is hypovolemic, and SIADH is a euvolemic state. So yeah, so just to go through the flow chart one more time. First step is to measure serum sodium less than 135. Next step, plasma osmolality. You measure plasma osmolality using the formula. If it's less than 280, that is what you call hypotonic hyponatremia or true hyponatremia. Next step is to calculate urine osmolality. If urine osmolality is more than 100, even if you're not able to calculate urine osmolality, a good history will be able to help you out with this. So most of our causes are ADH dependent. That means the urine osmolality is high. So once you know that your urine osmolality is high, you have to assess the volume status next. And if it is hypovolemic, after assessing the volume status, you have to measure the urine sodium. So if it is hypovolemic, your urine sodium is going to help you differentiate between the renal and extrarenal solute loss. So if your urine sodium is high, that means you're in hypovolemic state. That means you're losing sodium from the kidney, and it is a renal solute loss. Causes are diuretics, hypoaldosteronism, and cerebral salt wasting. And if your urine sodium is low in a hypovolemic state, that means your kidney is functioning normally. So hypovolemia and sodium, low sodium is not because of the kidney, it's an extra renal solute loss, causes us skin loss, bleeding, vomiting, diarrhea, third space leakage such as pancreatitis. And if it's euvolemic, the causes are, first you have to rule out endocrinopathies like cortisol deficiency and hypothyroidism. And after you've ruled out everything, SIADH can be an option. And urine sodium is going to be high in all of these. And if the patient is having hypervolemia, the causes are usually heart failure, liver cirrhosis, nephrotic syndrome, and your urine sodium is going to be low. Okay, so that brings us to the end of my part of the session. And Manju ma'am, if you want to add anything to diagnostic approach we've discussed so far, you're welcome.
Um, I think Jatin, you've already covered everything in very explicit details. So I think when we deal with some case scenarios in the next class, probably it will become a little easier to understand. Hyponatremia is very confusing and it seems complicated, but I think Jitin has done a very good job in breaking down each part so that we know why something is happening. So if everyone could just revise what has happened, I think when we deal with the case scenarios, it will become much easier to understand.
Yes, definitely. So as ma'am said, please go through I'll be putting up the slides in the group later. So go through the diagnostic approach before you attend the next class. So next class is when we'll be discussing how to treat hyponatremia. So we thought that if we did both of the sessions together, it would be too much. So I hope people are able to understand. If you have any doubts, you can ask us.
Hey, Jatin.
Yeah. Yes. Yeah, Anna, tell me.
I'm so sorry if you can't hear me. I've
Yeah, I
connected
can
from a
hear you. I
place
can
that
hear
doesn't have. Yeah. I just had a small doubt regarding this table. I remember at the start of the session, you did mention that basically serum sodium is like a direct correlation to serum osmolality, right? Osmolality. Does it work the same way with urine as well? Because technically, at the start when we check urine osmolality, doesn't that sort of give us a predictor to what urine sodium would be, or like how is it different? How does urine osmolality be high and urine sodium be low?
So you're asking how does urine osmolality be high and urine sodium be low? Okay. So
Exactly.
so- right. So urine osmolality is basically we are talking about whether a ADH is functioning or not. So that is why we are measuring urine osmolality. So if urine osmolality is high, we are saying it is ADH dependent. ADH is acting. So you're saying why is in a condition where urine osmolality is high, how can urine sodium be low? Okay,
Yeah, I mean, I'm
so
assuming like
yeah,
since the main thing contributing to urine osmolality is sodium, unless there's something else that's contributing to its osmolarity, how is it possible that its osmolarity is high and then the actual sodium content is low? Unless, of course, it doesn't work the same way as blood, because I remember you mentioned
mm,
the whole formula with like the sodium plus
yeah,
glucose by
yeah.
18 and
Meaning definitely there are other contributors to osmolality also, but at this point I'm not sure if we can answer your question properly. Manju ma'am, do you have any?
Yes,
Yeah,
yeah, yeah. So basically, in urine, the urea is a big contributor, whereas in plasma, what happens is urea doesn't contribute much. It's called an ineffective osmol. Because it cannot move, it doesn't shift as easily. It doesn't move between the intracellular and extracellular fluid. Whereas in urine, we're not talking about compartments. So in urine, the sodium doesn't play such a big role. In blood, it's important because it's one of those osmols that can easily shift between the ICF and ECF. So that's why it's the main contributor. Whereas when we come to urine, urine is just a single compartment. We're not talking about any shift. And so urea plays a equally like a bigger role than your sodium. The purpose of urine is to excrete urea. So urea is a major contributor here in urine osmolality. That's why the correlation is not there.
Oh wow, oh wow. Okay, thank you so much, Manju ma'am. I had another small doubt. I don't know if this makes sense, but basically, I remember when you were discussing the causes of hypervolemic hyponatremia, you also mentioned like nephrotic syndrome, cirrhosis, and all of that. And I remember how you went through the RAS pathway and then talked about ADH release. So is there like something that balances out aldosterone and ADH? Because technically aldosterone should increase serum sodium, right? So how does that effect come? Like, how do you know that ADH is playing a more prominent role than aldosterone when you have something like cirrhosis or nephrotic syndrome?
Okay, so actually, it is aldosterone that plays a bigger role in case of cirrhosis and all. ADH is there, but the main thing that we are concerned with is aldosterone. So you know that in cirrhosis, one of the main treatment we give is spironolactone. So cirrhosis with portal hypertension, the main treatment we give for ascites is spironolactone, which is an aldosterone inhibitor. So basically, what happens is the body senses in cirrhosis and like he went through the flow chart, heart failure and all. What happens is the body senses that there is a decrease in effective blood volume. what happens is the blood gets sequestered elsewhere. Like for instance, in cirrhosis, he talked about that splanchnic vasodilatation. So the blood gets hidden somewhere else. It doesn't reach the kidneys as normal. Or in heart failure, the cardiac output is less, so the blood doesn't reach the kidneys. So when the renal perfusion is decreased, renin secretion increases. That causes activation of the RAS pathway. And at the end of RAS pathway, aldosterone gets activated. So aldosterone activation causes sodium retention. With sodium retention, water gets also unnecessarily retained. So it's actually aldosterone which plays the main role there. That's why the treatment of all this, when we are treating heart failure or cirrhosis, one of the primary treatment we give is an aldosterone blocker. Once we block that aldosterone, the sodium and water retention is avoided and edema that the patient has will subside. So it's a mix of both, but aldosterone is definitely the primary problem there.
Thank you so much, Manju ma'am. So I guess like overall, it's really important to make sure heart failure patient does not have hyponatremia before we start like something like spironolactone.
No, basically what it tells us is that a patient with heart failure will have hyponatremia. That will be because they have excess free water. So when you give something like an aldosterone blocker like spironolactone, you're going to prevent that excessive free water accumulation. So just by giving the person diuretics, you're going to correct the hyponatremia. It doesn't mean that I have to give the patient excess salt and try to correct the hyponatremia first.
Okay, thank you so
Is
much,
it
Manju ma'am.
getting
So much.
confusing? I hope I'm not confusing you further.
Yeah, I mean, that made a lot of sense. Thank you so much.
Oh.
Okay, so I think we can wrap up today's session. So thank you everyone for attending. Thank you, Manju ma'am, for moderating the session and helping us make the concepts clearer. So as we mentioned earlier, like kindly go through the slides again before we uh, go into management. So we'll have the management class next. So we'll put out the dates as soon as it is confirmed. So yeah, so thank you everyone for attending the session, and we'll also be making the video available on YouTube. So uh,
Thank you all. Thank
that
you so
should be all.
much.
Yeah, thank you.